Can you put that away, please?
Of course.
Thank you so much.
It's somebody else's.
We have a few more people coming in. I just attached this to the course Blackboard site, and it's a pretty cool handout that I found. It's 6 easy steps for ABG analysis. So I can pass this around so you can look at it, knowing that I posted it for you on the Blackboard site. And in here is a cute little card that if you can get a better printing than mine, it would be kind of really cool to cut it and laminate it and then stick it in your lap coat pocket, especially for those of you that are in the ICU settings. It's a quick, easy guide to identifying respiratory versus metabolic versus compensating and so forth. So I can pass that around. Try and get as much of this voice as I can, so hopefully we'll be able to manage. Still willing to review tests with folks. It'll have to be today or next week because I'm spending the rest of the week doing clinical rounds. That way everybody's clinical rounds are done. Quick note on clinicals. Please be prepared in terms of assessment and medications. This seems to be a common thread that the clinical faculty have noted. I know you don't get your assignment the night before. I wish it was the case. It's not. You know how to look up drugs. But you've had pharmacology. You've had a year of med surg. You've got a common drug list. I really shouldn't be hearing back from clinical faculty that you don't know what Lasix is. I find that a little bit hard to believe. Okay, so we are expecting you to know these things now. You've passed the medication calculation module. You passed the medication safe administration module last year in clinical. You're not new to this. Please just kind of stay on top. I know you want to do more, but more than one clinical faculty has mentioned some concerns about medications. So just try to pull your end of the bargain up. Okay? And if you want to talk about it further, come to me afterwards. We're going to do respiratory over 2 weeks. So we're going to start with part 1 today. We'll finish with part 2 next week. We've got a lot of stuff to cover, so we're going to go quick. ABGs we will cover. You also have your handout. We will do ABGs again when we start talking about endocrine and when we talk again about septic shock, because then we get into more metabolic acidosis, alkalosis situations. Today we're restricting ABGs to respiratory acidosis and respiratory alkalosis. Mm-hmm.
Should we still be expecting a voiceover version?
Yeah, we're having a little technical difficulties. That will occur. Mm-hmm. Okay. In the meantime, you have the vascular PowerPoint slides that you can print out. Yes, we're looking at another way of getting that done, because obviously that's not a great way. It isn't getting things done. Okay. Okay, in terms of respiratory, I thought you might get a kick of this. This is a picture of the first mechanical ventilator. Things have changed since then, all right? Notice the oxygen tank here. This was done by mask. Patient was not intubated. Patient was, neck was hyperextended, the mask applied with pressure, and then somebody, in the absence of an electric motor or generator or oil-based motor, did a hand crank. This is probably about 120 years old, this picture. So the concept of mechanical ventilation is not new. It only took the Second World War to actually bring that concept into a prototype that could actually be tested. But this was the original version of mechanical ventilation. I'm not sure what this big wrench down here is for, but I thought you'd get a kick. This is an actual picture taken in the New England area during the 1950s when there was the massive polio epidemic that probably your parents or grandparents can tell you about, in which we had large numbers of individuals, both adults, young adults, and children, affected by polio to such an extent that they were temporarily paralyzed, including the muscles necessary for respiration. We didn't have a workable mechanical ventilator and intubation process at that point, certainly not to the level that it could handle thousands and thousands. So they were used in what was called the iron lung. And each one of these is an iron lung. On occasions, you still hear about a patient in an iron lung. I saw one in an iron lung about 15 years ago in Charlottesville at the Kruger Rehab. They were stretched out supine and flat on this gurney, almost like a stretcher on wheels, so you could open up the hatch and pull out the stretcher. And it worked by a bellows pump that increased negativity. Once this was closed, their head would stick out. You see the heads are sticking out here. And there was a kind of a rubber-style collar that fit around their neck to seal off the chamber. Inside the chamber, the negativity was increased to such an extent that their chest wall was actually sucked up into a deep inspiration position. And then the negativity went off and the chest wall relaxed. And that's how these folks breathed. You could have ports here, you could stick your arms through and actually do manual care, bathing, cleansing, wound care, and so forth. There was a mirror that flipped up. I think you can see the mirror here. So they would look at the mirror and then be able to see. And they were fed in this position. Okay. Let's talk about how we've really come quite far. In terms of respiratory function, we don't have time to repeat patho. But basically, the respiratory system is there to bring oxygenated air into the body using the large and the small airways. And then at the end of the small airways, we have a process called gas exchange, in which oxygen was pushed across the alveoli membrane into the nearby blood vessels, primarily the arterial blood vessels. And at the same time, the gas that's the result of metabolic waste, carbon dioxide, is pushed in the opposite direction, pushed across the membrane into the small airways, where it's then exhaled out. The respiratory system also plays a role in acid-base balance and in speech and in smell. Okay? So the structure, you have your airway that starts with mouth and nose, goes down to the larynx area. Beyond the larynx is the trachea. This is your main stem trachea. The trachea then breaks into two, and these are your main stem bronchi, the left and the right. I don't know if you can see, but did you see how the right is straighter and the left has this curve to it? When we intubate somebody and we're a little too eager, we tend to push the tube too far down, and just by ease, we tend to push the tube straight down into the right main stem. And then we check breath sounds, and we hear breath sounds on the right, but not on the left. So we know we need to loosen the tape and pull the tube back a little bit so it's positioned above both bronchi. Okay? So here's your right, which is almost straight, the left, which curves up. They then break apart into almost like the branches of a tree, into the smaller bronchi and bronchioles. At the tip are these clusters called alveoli. And if you can notice, on the outside of the alveoli is a very robust vascular system, primarily arterial, and the oxygen goes across the membrane into the blood, and the carbon dioxide goes across the membrane back into the airway, where it's then exhaled out. When we talk about barotrauma, pulmonary barotrauma, it means that somebody is on a mechanical ventilator with high PEEP, so high pressure, and all of a sudden the patient rapidly deteriorates and we lose breath sounds on one side. These alveoli have popped under the pressure of the ventilator, and we have an internal pneumothorax rapidly advancing because the ventilator is still pounding. We'll talk more about that later, but the barotrauma occurs at this end when the alveoli can't stand the pressure of the ventilator and just pop. Okay. We use chest x-rays also to assess respiratory function, basically its structure. And when you see the chest x-ray, it's both the lungs, but it's also the cardiac silhouette, the heart itself and the major vessels. I am certainly not qualified to read a chest x-ray beyond pneumonia and a hemo or pneumothorax, but the radiologist can look at this cardiac silhouette and identify far more details than you or I need to know. But basically, this is a normal set of lungs. Okay, it's a little bit, it's got that kind of haze over it, but I don't see big areas of pure white, and I don't see big areas of pure black. When you see areas of pure black, that's air. When you see areas of pure white, that's either fluid or tuma. Okay? I'll show you that. I was taught assessment by the look good, look bad theory. Standing at the door to the room, looking in at the patient, what looks good, what looks bad, and then moving closer to the patient, actually touching the patient and continuing the look good, look bad theory. So I thought this might help you. If we look at the look good column, the patient is relaxed in a relaxed body position, not using accessory muscles to breathe. These are the muscles of your upper chest and the neck. Have you ever seen somebody really struggle to breathe? And these muscles are just, you can actually see them contracting to try to assist to breathe. You don't see that in somebody who's doing okay. Breathing should be a silent process. You shouldn't be hearing it. If you're hearing it, it's a problem. The patient should be able to talk to you with ease. The first sign of somebody being in trouble, they cannot talk. They don't have the air to talk. That's your first indication that they're in problem. Their cough is strong. Their skin is pink or natural to their culture. Respiratory rate is about 20 per minute, regular and unlabored. I can have a respiratory rate of 20 and labored, versus 20 in unlabored. The difference in the adjective tells me which patient's in trouble. So the number alone is useless. Okay? Is it regular and is it unlabored? Saturations on room air should be about 95 to above, unless they're a long-term COPD patient, then they'll be slightly less than that. Each breath should be deep, should be relaxed, should be symmetrical, and shouldn't take great effort. If they're coughing up sputum, it's minimum and it's clear. If you check their breath sounds, they're clear throughout. Their blood gases and their chest x-rays are normal. So that's the look good patient. Now we go over to the look bad patient. He has to sit up and lean forward to breathe. You can see the muscles of the neck and the upper chest contracting to help establish that breath. You're hearing him. You're either hearing him with that awful stridor or you're hearing him wheeze. He cannot talk to you easily, maybe a word or two, but at the most, that's it. Cough is weak. Skin color has changed. You're seeing some pallor, you're seeing some cyanosis. In individuals of color, look for the lips. Okay. Respiratory rate is either slow, rapid, or irregular. O2 stats less than 95% on room air, or despite oxygen therapy. Breaths are either shallow, asymmetrical, or labored. SOB means shortness of breath. It's another term for dyspnea. DOE means dyspnea on exertion. They're okay lying in bed, but when they walk to the bathroom, they get short of breath. And orthopnea means they have shortness of breath when they lie flat. Typically, your congestive heart failure patients. Okay? Sputum in them is either increased, tenacious, tan, green, for example, if they have pneumonia. Sorry, this should be pink. Pink and frothy. That's classic for pulmonary emboli, or hemoptysis, which is bloody sputum. If you listen to the breath sounds, you're hearing abnormal, diminished, or absent. We'll go over that in a minute. And their blood gases in their chest x-ray are abnormal. Okay, so I think this might be easier, the look good, look bad theory for you. In terms of the breath sounds, this is what, you're not a respiratory therapist, you're not a pulmonologist, but this I think is quite appropriate. You should know the difference between these four. Crackles or rails, you'll hear the term used interchangeably. It's a popping sound as if you poured milk onto cereal. Okay? It may or may not clear with cough. It might clear with bronchitis, but in a bad pneumonia, it may not. And what it is the air is moving over any fluid in the airways, and it's kind of bubbling things up, and that's what you're hearing. Wheezes are squeaky sounds. They represent a partial obstruction of the smaller airways, such as in asthma. Rhonchi also reflects obstruction, partial obstruction, but of the larger airways. That's not squeaky, it's more like a snoring sound. And then pleural friction rub. You've got the lining outside your lungs. You have a bit of space called the pleural space. It's got a little bit of fluid in there for lubrication. And then you have a second lining. And if those linings are irritated, they will rub together, and on a deep breath, you'll hear this grating sound, and it's a pleural friction rub. For example, anybody ever had pneumonia so bad you had pleurisy? That every time you coughed, you felt your chest was going to break apart, it hurt so much? It means that there's some inflammation and the pleura rubbing against each other, and you would hear a friction rub with that. There are some tests that we do. One of them is a pulmonary function test. Nurses in respiratory clinics and pulmonary clinics often do this. In the hospital setting, we see the respiratory therapist doing it, both in the acute setting and in the clinic setting. And this is just a simple test that's done to assess how well you can take a deep breath and how well you can exhale. Very, very important to identify patients who are at increased risk for post-op complications, such as atelectasis and pneumonia. These are our smokers, these are our elderly folks, these are our chronically ill folks, and anybody who has any sense of neuromuscular deterioration. Multiple sclerosis, for example, okay? It identifies how well they take a deep breath in the best of circumstances, and then we can identify how much anesthesia risk they will be post-op. It can also be used to assess treatment. If I have a child in trouble with asthma in the ED, I'm going to treat them medically, and then I'll do a PFT follow-up to see has it really improved their ability to breathe. Very easy. It uses something like this. It's different versions of the equipment, but this is one. And the patient, this is the mouthpiece. The patient pretty much breathes into this. Okay. Basically, there's only, there's a whole list of things you get from a pulmonary function test. These three are the biggies that I think are applicable to nursing. The total lung capacity. Okay. Take the deepest breath possible. What you're measuring is how deep is that breath in the best of circumstances. So what is the amount of pressure at the end of a very, very deep breath? Forced vital capacity, you take a deep breath, and then you try to exhale it quickly all at once. Okay? That's seeing how strong is your ability to exhale air. And in kids with asthma, they have problems with this. And then residual volume. How much air is left? How much air couldn't get out? Okay. So I think these, of all the pulmonary function tests, only these three are really important for us as nurses. There's a simple device called an incentive spirometer, and I'm sure you guys have seen them by now. There's different shapes of them. Each company has their own shape. It is a simple plastic disposable handheld device. Should be given to all patients following trauma, pneumonia, or major surgery. And its main purpose is to prevent atelectasis. Atelectasis, I'm sure you remember, is when those alveoli collapse, often because of prolonged immobility or post-op immobility. And this is used for pulmonary toilets so that the patient is taking breaths that are so deep and so sustained that the alveoli do not collapse. We use it to prevent or treat atelectasis post-op. It's also good for patients who have pneumonia to use as well. Any major health crisis that is going to cause an immobility for a while, it's good to have one of these. You don't blow into it. You can always tell the patient who hasn't been instructed properly because they're killing themselves trying to blow into this thing. You don't blow into it, you breathe off of it. Okay? You take a slow and deep breath. And then when you can't inhale anymore, you hold it. And that back pressure is what repops open those alveoli. So it's not just taking the deep breath, but it's holding that breath for a couple seconds that the benefit of this device is. What's nice is that it has markings on it, so you can compare where they are now, where they should be, and areas for improvement. And those are marked off. So here's a classic shape, although they come in different shapes. Mouthpiece goes in, and do you see you breathe off of it, you don't blow into it. As you breathe, this blue bellow is raised. This marking has been put, you can adjust this as well, move it up or down to where you want them to aim to. At the moment, this looks like it's about 1,700 cc's. And so you want that patient to take a deep breath to try to get as close to that benchmark as possible. And then this will rise also with the deep breath. And you want to, when you've taken your deep breath and you hold your breath, you want to hold that ball up in the air here. It's just a visual to help the patient. I had a cute little guy once, and he got sick and tired of us harassing him about this stuff. We had set this thing to 1,500. And he on his own said, no way. So we caught him bringing this thing down to 1,000 so he wouldn't have to work so hard. But it's a very valuable tool, and we just don't use it often enough. Okay. Moving into our ABGs. ABGs are arterial blood gases, commonly drawn from the radial artery, but they don't have to be. They can be pulled off of any artery. You can do a brachial stick. You can do a femoral stick. Okay. But commonly, we use the radial artery because it's very accessible. This just shows you've got two arteries actually running down into your wrist. The radial is the one we tend to use just below the thumb, but the ulnar is over here. We don't tend to use the ulnar because there's a nerve nearby it. Okay. And we'd rather not get that nerve by mistake. Okay. First, you have to do the Allen test. Okay. Now, respiratory is the one who primarily does this. Very rarely do you see nurses do an A-line stick, okay, respiratory. But you will see them do the Allen test. And what they're doing is they're going to obstruct both arteries at the wrist for a moment, and then they're going to let one thumb up and test the circulation ability of that unobstructed artery, and then they're going to do the same. Because this artery here, the radial, is the one we use the most, we're concerned about any kind of obstruction in the ulnar. Just in case we damage this artery, develops a hematoma, if I have a massive hematoma here obstructing arterial flow, and I have a messed up ulnar artery, this hand's going to go without circulation. So before we do an ABG or even put in an A-line, we do the ulnar test and verify that while we're using this artery here, we have this one fully open for perfusion in case we damage the radial artery. Okay? This just shows you two ways. In this case, we're doing a needle stick. In this case, we're drawing blood through the stopcock off the arterial line. The arterial line is in the right radial. Okay. You don't need a lot of blood. You have to use a special ABG syringe because it's got a little anticoagulant in it. And then the specimen gets put on ice and sent off as a stat for analysis. Most ICUs have a respiratory machine in the unit so that the ABG can just be run immediately. The nice thing about the ABG is you can also get a stat glucose off of it and a stat crit, and in some machines a stat potassium level. Okay. Now, in terms of analyzing the results, particularly we're looking at a handful of elements here that we're worried about, that we're going to look at. The arterial blood gases basically determine if gas exchange is sufficient, not only gas exchange, but then does that oxygenated blood move around the body. Okay? We're looking at, are we in a normal state? Are we in a respiratory acidosis state? A respiratory alkalosis state? Are we in a compensatory mode? We're being pulled out, the body's trying to pull us out of one of the abnormal states. And then hypoxemia. Hypoxemia is separate from respiratory acidosis. So ABGs will say respiratory acidosis with hypoxemia. Okay. Hypoxemia is the oxygen within the blood. But acidosis is not based off of that number. It's based off of pH, okay, CO2, and HCO3. Okay? So the report comes back acidosis with hypoxemia, for example. Okay? We use ABGs when there's a respiratory crisis. We also use them when there's a metabolic crisis, because then you're talking about a metabolic cause for acidosis and alkalosis. And so you'll see this used frequently in septic shock as well. And then, of course, we use it to determine if the patient needs to be intubated and ventilated, as well as how well is our treatment of the patient. The ABGs will improve after somebody's been intubated and ventilated, and so that just verifies that what we did was correct. These are the elements of the ABG I'm going to hold you to. Okay. Sorry, the top four. The lower one is pulse oximetry. Okay, oxygen saturation through the skin, and that you compare against the ABG. The top thing is the PaO2, and that's the partial pressure of oxygen in the artery. Normally it's 80 to 100, and it's reported off as pressure, so millimeters HC. Okay? So 80 to 100. And then PaCO2 is the partial pressure of carbon dioxide in the arterial blood. Okay? And that's normally 35 to 45. What you see in a respiratory failure crisis is that the two move together, and we usually say the 60-60 rule. If the PaO2 is down to 60 and the PaCO2 is up to close to 60, you better have a tube in that patient. Okay, so in failure, these two will move closer together. Now, it's the CO2 that induces the acidic state. And so those numbers will be in reverse. The higher the CO2, the lower the pH. It's an inverse relationship. Okay, so as the PCO2 goes up, it induces acidosis, and when there's acidosis, the pH is low. Okay. In reverse, when there's an alkalotic state, okay, the pH goes up. Okay. Now, the pH of the blood, normally in the average adult under 60, and the healthy adult under 60, is 7.35 to 7.45. If the blood is acidotic, it will be less than 7.35. If the blood is alkalotic, it will be higher than 7.45. And then we also measure bicarbonate, HCO3. If bicarbonate is being used, we will see it being used to pull somebody out of acidosis. And I'll show you that in a minute. So respiratory acidosis will be determined by these two, PaCO2 and pH. Hypoxemia will be determined by PaO2 and O2 sat. And whether or not the body is compensating for that will be determined by the bicarb level. Does that make sense? Okay. This is another little chart that I think might help you. Okay. So in acidosis, the pH goes down, the CO2 goes up, and this is an uncompensated state, so bicarb remains the same. In respiratory, I'll be right with you. In respiratory alkalosis, pH goes up, bicarb goes down. PaCO2 goes down. Remember, reverses. And then bicarb is not being used, and so that stays normal. Let me show you one with compensation, and I think it might. Okay, well, we'll get to that. This is respiratory acidosis, which is probably going to be the majority of what you see. And this is from hypoventilation. They're not breathing adequately. They're not breathing sufficiently. They may not be breathing at all. This could be due to trauma. It could be due to too much anesthesia. It could be to too much narcotic, too much sedative, or something clinical, like overwhelming pneumonia. Okay? Now, remember, an acidic state is a sleepy state. The patient will be drowsy, level of consciousness will drop, everything slows down. So just remember, an acidotic state is a sleepy state. Okay? They're floppy, they're very weak, they're very tired, they're lethargic, the level of consciousness goes down, the blood pressure goes down. It's kind of like that scene from The Wizard of Oz when they're, in the poppies and they all fall asleep. Okay, kind of look what they look like. In the alkalotic state, this usually see this in a hyperventilation state, anxiety, for example, or we're using too much of the ventilator. The ventilator is breathing too much for them. We've got to turn down the vent. Okay. Alkalosis is a wake-up state. So you see tachycardia. You see rapid breathing. Okay. They still don't feel well, but you'll see the tachycardia and a little bit of hypertension. It's kind of a wake-up state. But you also see this numbness in their fingers, too. They'll say their fingers are numb, their lips are numb. You don't see it very often. Now here we go, okay? Acute respiratory acidosis, so we have the inverse. pH goes down, okay? PCO2 increases, okay? When we're compensating for that, the body throws bicarb into the mix to try to offset the acidotic state. So you'll see bicarb used. So the bicarb level will start to drop on the EBG because the body's using it to neutralize the situation. Okay. In alkalosis, the pH is up, the CO2 is down, and then we see bicarb going. The body doesn't need to make as much bicarb. It's already in alkalotic state. Okay? We'll practice this again next week, too. Okay? Now, did any of that answer your question?
I was going to ask you to repeat what you said. You said that hypoxemia is indicated by the PaO2.
And the pulse oximetry.
Okay, that's what it was.
Yeah. Okay. Acidosis is determined, alkalosis acidosis is determined by PaCO2 and pH. and degree of compensation in a respiratory state is indicated by the use or the not use of bicarb.
Okay.
Okay?
Thank you.
All right, we'll keep plugging away at the ABGs. We'll be doing more next week. We'll be doing more as we talk about endocrine disorders such as DKA. We'll be doing more as we talk about septic shock. All right, let's move into some airways. First one is the oral airway. It's a rather clear, stiff, rigid plastic, a curved device. Okay? The thing about the airway, the oral airway, is you insert it upside down. And then halfway you turn it. Because if you were to insert it in its regular direction, you would push the tongue back. So it's inserted upside down. See this? Inserted upside down, and then it's twisted, and make sure you're over the tongue before you twist it, and then it slides back into position. But if you were to go from it just from this angle, you'd push the tongue back. You can always tell when somebody's really out because they'll never let you put one of these things in. And you can always tell in the recovery room when they're waking up because they pull it out. They either cough it out or they pull it out. It's not a fun feeling. Okay? If they let you do it to them, they're in a bad state. Okay? The nice thing about this is it allows air to get past that floppy tongue. If they're acidotic or heavily sedated, their tongue is floppy and can slide back and obstruct. So the oral airway allows you to ventilate beyond the tongue. It also has a little bit of a hole in it. They say you can suction through it. The reality is, unless you get the smallest pediatric suction catheter, nothing fits through that thing, okay? We also have been known to use these as bite blocks, not in seizures, but in intubated patients. You don't want to use this in a seizure situation. They'll just break their teeth on it, okay? This is the nasal airway. It tends to be like a piece of rubber, like a red rubber catheter, that kind of feel. It's not clear. It's flexible, it's floppy. It gets inserted through the nose, but when you insert it, you can insert it in the true direction, but you have to push on the nose and lift it up again, up a bit. And remember to use lubricant. I've seen way too many cases where they've tried to jam a nasal airway into somebody without lubricant and caused a nasty nosebleed. So Surg lube is good. The alert person will let you put one of these in. The semi-alert person will as well, because it's soft and it's not rigid and it's very comfortable. They tend to leave these alone. And usually you can suction through this. It is the diameter here is larger than that tiny hole in the oral airway, but you still need a smaller catheter to do so. These are nice to have if you've got somebody that you have to suction frequently and you're afraid that every time you go through that nose you're going to damage the nose. You can put this in and then pass the catheter through this, every time you need to suction. It's a lot gentler on the nose. Very easy to take out. You just pull it out. Okay. This is the endotracheal tube. We can intubate somebody with this through the mouth or through the nose. Obviously, we prefer through the mouth. It's a little bit easier on all involved. But if somebody does have mouth trauma, they will use the nose. It's a long tube. It's a clear tube. It has a radiopeg line on it so that it shows up on X-ray. That way you can tell if it's in the right position. It has line markers. That way you can monitor how much tube is extending beyond the mouth and determine if the tube is slipping out of position. It is a cuff tube. So you have your cuff port here, and then you have your universal adapter here that will fit to any oxygen equipment, any ambu, and any ventilatory tubing. It's inserted using one of the blades, usually for the adults a curved blade. You're using this has a little light bulb on it, and when you lift the handle up, you kind of lift, this thing folds against the handle, so this comes down here. When you lift it up, the light is activated, and what they're doing is they're looking for the vocal cords. The light will help them visualize the vocal cords, and then the tube is slipped between the vocal cords. And then this blade then is pulled out, and the tube remains. We'll talk more about endotracheal tubes in a little bit. This is a pretty cool thing. It's been in use, I want to say 15, 20 years, often used in anesthesia for simple cases. Maybe somebody's just getting some deep conscious sedation and, for maybe a lumpectomy. I don't need to ventilate them, through a mechanical ventilator. I will sedate them, I'll put an LMA in, and I'll support their breaths with ambu breaths on oxygen during the short surgery. It's called a laryngeal mask airway, or an LMA. It's actually inserted like an NG tube, because you are actually inserting this into the esophagus. Trachea is the forward, esophagus is the back. You insert it into the esophagus, and then you seal off the esophagus with the cuff. The tube is here, and what you can't see is the tube ends about here, and then you ventilate through the end of the tube into the trachea. The nurse anesthetists use this a lot. It's a nice device. Tracheostomy. I know you've had trachs before, so we'll kind of go through this a little bit quick. But what a trach is when you surgically create a hole in the neck by pulling the trachea forward to the skin and kind of opening it up a bit. And then slipping a tube in through that incision so that ventilation bypasses the mouth, the nose, the larynx, the pharynx, and goes directly into the trachea. It can be done on an elective procedure, such as certain surgeries. It can be done on an emergency procedure. In all my 34, 35 years, I've seen 3 emergency trachs in the ICU. Professor Taylor was with me the day we had to do it in the burn unit. It was quick. That was an awful shift. And patient was intubated and ventilated, but obviously developed a plug in their endotracheal tube that was a flap plug. So this mucus kept flipping in and out of the tube. Respiratory took the tube out to manually ventilate them. We couldn't ventilate them well, and we had to call a surgical stat. And unfortunately, it was a general surgery resident who was the first one. He was a first-year resident who was the first up on the unit. ENT didn't answer the stat page. Nobody else answered the stat page. And Jane and I had to talk this young resident through the steps of doing an emergency trach, and he did very well. But we were throwing betadine all over each other. Temporary or permanent indications, anything wrong with the upper face and neck. Trauma, surgery, extreme swelling. Anything that's going to threaten the upper airway is an indication. Tumor, thyroid tumors, for example. High prolonged aspiration risk. And if they are on a ventilator longer than 2 weeks, you have to take the endotracheal tube out and do a tracheostomy procedure. Okay. So here's your trach. It goes in front of the neck, kind of right around here, and opening. This is the esophagus. This is your trachea. So you're bypassing the nose, the mouth, the pharynx, the larynx. Okay. Different kinds of tubes. Probably the one you're going to see the most common is from a company called Shiley. This is a classic Shiley tube. Another big company is called Portex. Okay. This is a cuff tracheostomy tube. You can see this blue line is a radiopeg line that will show up on X-ray. And here's the cuff. I'll show you a picture in a minute. This is the cuff port. Okay. This is a Shiley. So here's with the cuff up. You insert air through this, a one-way valve to prevent the air from leaking out. This is a dual cannula tube. This is the outer cannula. This is the inner cannula. Shiley produces 2 sets of trach tubes, one in which the inner cannula is meant to be cleaned and put back in, and another in which the inner cannula is a disposable. It's a DIC, disposable inner cannula. That's probably what you've seen the most of in the hospitals. Okay. This is called the obturator. When this was put in, the inner cannula was taken out. The obturator was put in through here so that this round area was protruding from this. That allowed smooth insertion of the tube. And then this obturator was taken out, and the inner cannula, which has an open aspect to it, was put into the tube. Okay? You need to save these obturators. They usually send them back in a Ziploc bag because this obturator was made to fit this tube. Should that tube ever come out, you need the obturator to get it back in. And this shows you what the cuff. When the cuff is inserted, it's going to obstruct that air, obstruct that space between the outer part of the tube and the wall of the trachea. We do that for two reasons, one of which is to prevent aspiration. It doesn't really prevent them from aspirating, but the aspirated material stays on top of the cuff and doesn't go down to the lungs. Also, if we are mechanically ventilating them, all the air is going to go down to the lungs, not come out the tube and take a U-turn and go up to the mouth. So when you ventilate somebody on the ventilator, the cuff has to be up. Okay? From the outside, this is a Shiley, this is a disposable inner cannula. You can use trach twill, or you can use the pre-made, prefabricated trach holders. Some of them are better than others, though, but there's some good ones out there. And you have to use what's called a trach sponge or a T-sponge. These are pre-cut gauze. You need the pre-cut because if you decide to cut one yourself, you're going to release a whole bunch of fibers that are part of the stuffing of that gauze, and then this person can inhale those pieces of fibers. These are pre-cut so that there's no fibers hanging around. How often do we change this? At least once a shift. And you need this size inner cannula must meet this size trach tube. You order them up as a box of 12, for example. And so you order the patient, a box of them and keep them at the bedside. You can't fit a size 8 inner cannula into a size 6 tube. They have to match in size. Okay? In a crisis, you can clean these and put them back in. Okay? There's also metal trach tubes, but they are always uncuffed. These you're not going to see in the acute setting so much as in the chronic setting, maybe the nursing homes, the rehab homes, the SNF facilities. These are long-term trach patients. The benefit of metal is that there's not the cost of disposable equipment. They too have a certain size to them. This is the outer cannula. This is the inner cannula. This goes into here, and you see this little hinge? Once you put the inner cannula in so that this is flat against the faceplate, then you turn this hinge so it holds that inner cannula in place. Okay? And then this is the obturator for that tube. So,
When you said you have to change it once a shift, is it just
the disposable inner cannula only. Yeah. Okay, trachs are always on NCLEX because they show up across the entire spectrum of med-surg. These are more for post-op tracheostomy guidelines. When they come back, you want the original obturator and you want an extra trach tube of the same size up on the unit. They usually tape the bag with the obturator to the chart. And then you need to determine, does this person need oxygen? Do they need to be on the vent and do so? Okay. You also need to determine, does the cuff need to be up or down, and the physician's orders will say that. And you use what's called the minimal air leak technique for inflating the cuff. You inflate it only until it's just inflated, because if you overinflate these cuffs for too long, you'll cause necrosis of the trach wall that the cuff is leaning against. So minimum air leak technique. Respiratory is great about doing that. They have this little handheld device that hooks onto that cuff port and measures the pressure that's in that inflated cuff. Okay. These guys need humidity and they need filtration. They're no longer breathing through their nose. They're breathing directly into their trachea. And so they're going without that warming and filtering ability that the nose offers. The room air has to be humidified, or they're on a trach collar that has humidity, either humidified room air or humidified oxygen. And then you can't filter, but you minimize irritants in the room. This is not the room that you're going to use the spray can all over. Okay? You have to be careful of spray cleansers, the deodorizing air spray, people with perfume, any kind of fumes. Obviously, nobody should be smoking around these folks either. Wound care, this is a surgically created stoma, so you've got to clean it. Usually you use like a diluted peroxide, then rinse off with saline, and then dab at it with some bacitracin. That's usually once a shift. The intercannula we talked about, either you replace it or you clean it and put it back in. The trach ties, you want to tie this, if you're using the twill, so that there's 2 layers of twill and you can get at least 1 finger between the twill and the neck. Changing the trach ties is a 2-person job, and you put the new ties over the old ties before you cut the old ties off. These guys need a lot of mouth care, just because they tend to be mouth breathers. They always seem to have their mouth open. So mouth care and suction is needed. They also tend to be dehydrated, so make sure they're well hydrated. And depending upon the underlying cause, there may be some problems with swallowing. There are patients who have trachs who can eat, but you need to assess diet with the physician, and if the patient cannot eat, then usually the means of feeding them is through tube feedings, enteral tube feedings, J-tube or a PEG tube. They cannot talk verbally. They can communicate, but they cannot talk. They tend to communicate sign language, pointing at things. They usually have a piece of board or paper, and they're writing all over that. So you need to establish some kind of alternate communication. These aren't the folks that are going to put their room light on and answer when the intercom, when the guy at the front desk hits the intercom and says, "How can I help you?" They're not going to be able to answer back. So you've got to label your intercom. And then patient education. Often they need to learn how to take care of themselves when they go home. Just stretching? Okay.
No,
Yeah.
When would you not need, what patient would need the complicated? What patient would need the complicated?
If they're going to be going home on a trach, say it's a cancer patient with a massive thyroid tumor, they've chosen not to have surgery, or surgery is not an option, and they're not an aspiration risk, then they would be changed to usually an uncuffed tube at that point. But acutely ill, we prefer to have a cuff tube in place in case they deteriorate and we need to do respiratory support. We could quickly inflate the cuff and bag them. Okay. For those patients that fall into the category that they're going to be chronic, they're going to have this tube, it's going to be okay for them, it's mainly for airway, it's okay to let them speak. We use what's called a fenestrated trach tube. And so the other one comes out and a fenestrated trach tube comes in. The fenestrated trach tube has a hole right here at the arch, and it is uncuffed. So when they take a deep breath, air can come down, air can go up, and air can go around. To speak, you need air going around the voice box, around the larynx. Okay? So we changed it from a cuff Shiley, to a smaller size fenestrated tube. And then we start talking, but they'll have to obstruct the front of the trach to talk. Sometimes they do it with their fingers, sometimes we use the plug. Whenever you see a red plug on, know that that patient has a fenestrated tube. And so should this patient go into crisis, the first thing you do is twist off the red cap. Twist off the plug. And you can tell this is fenestrated. See, it says no cuff, and over here, FN. Fenestrated. Okay. Should this patient rapidly deteriorate, though, we're not going to be able to bag them successfully through this tube. So whenever somebody has a fenestrated tube in position, always have a cuff tube of the same size on the unit. If there is a deterioration, we pull this one out, we put in the cuff tube, we inflate the cuff, and then we bag or ventilate by machine. Okay? Moving onward, this is a laryngectomy patients. Laryngectomy is an artificial airway, it's just surgically created. People have attempted to drink lye cleansers as a suicide attempt. And it is an elective procedure. It's never done on an emergency. There is some preparation done to the patient and family, but in all my years, I've never seen a patient who the preparation totally prepared them. There was always a massive post-op reality shock when they woke up, even though the chart said they had been talked to, they had some, regardless of the prep effort, it's a big emotional shock when they wake up. They are a permanent neck breather, which means should they collapse, you can't do mouth-to-mouth to them. You can't ambu them to the mouth. Ventilation will have to be done totally through the neck. And then, of course, a massive body image change. Okay? So here's your pharynx and your larynx. In this picture, they have been surgically removed, and the trachea here has been brought to the skin, and here's the laryngectomy stoma. This is often done in a procedure called a commando procedure, which is a total head and neck resection. And the laryngectomy is only one part of that procedure. They have probably also lost all or a portion of their tongue, a portion of their jaw, their larynx, and then they've had the soft tissue around their neck dissected. So they will probably come back with a laryngectomy stoma, incisions here, incisions up the neck, incisions starting from here around their jaw, probably incisions going up here, chunks taken out of their mouth as well. It's just a massive, massive procedure. Okay? This is what a healed laryngectomy stoma looks like. Post-op wise, we do put a tube in because there's a fair amount of swelling, and we need to keep that stoma open until swelling goes away. But they will not have the tube forever. The tube is then removed close to discharge, and they breathe through this hole here. Okay. Post-op care on these guys, this is always done under general anesthesia, and you're talking an 8-hour procedure. So there's a lot of anesthesia, there's a lot of fluids. This is done as a teamwork between plastic surgery and the ENT surgeons. It's just massive amounts of surgery, massive amounts of as a skin graft, because when they resect the neck, they tend to patch over the carotid artery to give it a little extra protection. So there may be a skin donor site. They may have dissected a bunch of tissue here, and they may have taken some muscle from the back or the stomach and freely resected it and then implanted it to fill in the gaps. So it's ICU stay for at least one night, if not several. You need to closely monitor them for fluid electrolyte balance, for bleeding, especially around that neck. Should any one of those ligatures come loose, this neck is going to puff up with a hematoma, and then that stoma will be obstructed. Okay? That's what we call interior neck precautions. We'll be talking about them more. Head of bed elevated, as long as the blood pressure is stable. The neck and head have to be in alignment. They're supine. Okay? There's large bore, short tube against the tube against the swelling. They will have Jackson Pratt drains coming out of around here, IV fluids, tube feeding, lots of surgical wounds. It's a real team approach. Respiratory is up there a lot. Social worker is involved. The dietary folks are involved, and then the surgical team themselves. Speech therapy comes on board. Ideally, they see the speech therapist before surgery so that she can kind of introduce strategies for alternative speech so that post-op they can implement those as soon as possible because some of that teaching's been done. I have seen them have a laryngectomy buddy. In some cases that helped, in some cases it didn't, but it should be offered. This is an individual who had the same kind of surgery and is willing, they're fully recovered, they've adapted to life, they're willing to come in and do some hand holding until this patient too adapts to life. Those are referred by the American Cancer Society. Eventually, when they're healed enough to look at alternative speech, there's a couple things they can do. Have you seen the electronic larynx? This little handheld device, they hold it against the side of the neck, and it has this robotic vibration tone to it. That's something that can be implemented quickly. The TEP procedure is something that has to be done further down the line, and that's when they puncture a hole in the esophageal tracheal wall, and these people learn how to do esophageal speech. You ever seen anybody do esophageal speech? There is a public announcement out on TV. It's one of those anti-smoking announcements. And it's a middle-aged lady who smoked for years, and she talks about when she reads her grandchildren a bedtime story, they don't recognize her anymore. So that if you want to you want to smoke and read to your grandchildren, record your voice down. And her way of talking is it's kind of, she has to swallow the air and almost burp it up, and only a couple words at a time, and that's esophageal speech. Okay, they have to wear a laryngectomy apron that acts as a filter so that things aren't sucked into this. And then they wear a shower guard when they shower. They can no longer go in the ocean, in a pool, or in a bath, because obviously drowning would occur quite quickly. Okay. Discharge planning, we got to look at the home situation. If we're sending them home and there's all sorts of pollutants and irritants in the home, that's not going to help. They have to turn up the humidity of their home. Often they have to adjust the filter and to increase the humidity of the furnace or the central ventilation system, or get a humidifier device. They need to know they have to constantly sip on water, and they have to be fully nourished. They need to know how to suction themselves in case of emergency, as does their family. They need a medic alert, alternative communication means, and we always used to recommend that the nearby fire department and police department have some notation under that address that a laryngectomy patient lives there in case they dialed 911 and can do no further than dial. Okay. All right, so let's move into oxygen. Oxygen is a medication. You need an order. Now, practically we tend to use it and then get the order second. And usually we have good justification, so nobody bothers us. But it is a gas, it's prescribed gas. We use it to increase the oxygenation going into the body, hoping that that will then transfer over into gas exchange of more oxygenated blood. It is for relieving symptoms. Oxygen in itself is not a cure. It is just symptom management. If the underlying cause of their shortness of breath and their hypoxia is pneumonia, oxygen will not cure that pneumonia. Antibiotics will cure the pneumonia, but oxygen just relieves the symptom. Okay? We determine the amount of oxygen by a term called FiO2%. It's the fraction of inspired air. And then we adjust that fraction, how much we want to give to them, based upon the delivery system that we've chosen. The rule is we use the lowest amount of oxygen for the shortest amount of time. And that's regardless of the age, because it does have problems with it. And then COPD patients, you have to be careful. We were taught that the COPD patient's respiratory drive was not driven by higher levels of CO2, but by lower levels of oxygen. Now they're telling us that was all crazy. Yet normally they do have a O2 sat that's slightly lower, but when they need oxygen, we should be giving them oxygen and not withholding that, but we may have to give it in more of a protective environment. Like if they need O2 seriously, we need to get them off the general ward and get them into a step down, a progressive ward, in which we can just watch them closer. Okay. And any patient that's on oxygen and exhales out of these holes in the side of the mask. That's a simple mask. We move over, as the patient deteriorates, we move over to a partial rebreather in which the patient, oxygen is fed into this reservoir bag, and the patient breathes out of the reservoir bag, exhales out of holes in the side of the mask. But the problem is there's no wall between the mask and the reservoir bag. When they exhale, most of will come out of the mask, but 1/3 of exhaled air will remain between the mask and the bag. They can actually breathe back down into the bag and mixing, so this is no longer pure oxygen. If they don't tolerate that, then we move them down here to a non-rebreather mask, in which there actually is a one-way valve right here. So oxygen feeds into the reservoir. This reservoir remains pure because when they exhale, the valve shuts down so that they can't breathe into the bag. They have to breathe out of the mask. Okay? So if they don't tolerate this, they're intubated. Okay? They've gone from the non-rebreather to intubation. Patients who are COPD patients, and we need to really fine-tune the amount of oxygen they get, we use something called a venti mask. I'll show you a better picture. Here's your non-rebreather. They exhale out of here, but when they inhale, these aren't just holes. They're holes with a little flap over them. When you exhale out, the flap is lifted up. But when you inhale, the flap is kind of sucked down. So the only source of inhaled air comes from this reservoir bag of pure oxygen. When they exhale, this one-way valve closes down, these open up, so the exhaled air, or the majority of it, goes out of the mask and not into the bag. Okay? Now, a little bit of exhaled air will remain in the mask, but not much, and this stays pure. I have this chart for you, okay, which talks about what the flow liters should be on the wall and the percentage of oxygen. Okay? Room air is about 16 to 18% oxygen. So the lowest, if we start low, we start with the cannula, 2 to 4 liters. You can use the cannula up to 6 liters, but you need humidity more than 4 liters. Okay? So average is 2 liters. So you're talking about 25, 26% oxygen if it's nasal cannula at 2 liters. It's a little bit more than room air. In most cases, that's sufficient. If they don't tolerate this, we bring them down here, and it gets them 40 to 60. Okay. And then from here, we go to the partial rebreather, which gets them, sorry for the typo there, 60 to 75. If they don't tolerate this, then they go to this, which is 80 to 95. If they don't tolerate this, they're intubated. Vomit into the mask and then aspirate. So that's why the masks are clear. You can see through. Just be careful. This is the venti tube. Now, NCLEX goes into oxygen safety. Oxygen itself is not flammable, but what it will do is it will make the substances and the materials around it more flammable. And that way we have to ensure oxygen safety. So you have to be careful of the materials that are around any patient's oxygenated room. We use hospital linen only because it's low static. No candles, obviously, no flame, no smoking, no birthday candles. Professor Taylor and I were working the weekend once up in the burn unit at UVA, and it was like this L-shaped unit, and the folks who were close to discharge, we had them down the hall, and one of the guys in the big room down the hall was having a birthday, and his family decided they were going to celebrate this birthday and sneak in a cake. They came up the back staircase and walked into this room, and it had like 35 lit candles on it, and all we can think is, oh my God, the whole burn unit's like going to go up in flames. And one of the staff nurses just took the nearest thing she could find. It was a vase, it was flowers in a vase of water, and just threw the water onto this birthday cake to quickly douse the candles. It is a risk. It is a risk. The OR is the place where it's the most risk because of the amount of oxygen that you use in there, and that they do use things such as the cautery and a lot of electrical equipment. So that's another reason why folks working in the OR have to wear OR garb. And that if they wear shoes, they have to be non-static shoes. Okay. All electrical equipment must be grounded and have a safety sticker on it. That's for us IV pumps, glucometers, O2 sat and vital sign machines. There used to be the myth that you couldn't have any alcohol or any oil in the room at all because they're flammable. And so I remember seeing an older nurse ream a younger nurse because she had used petroleum on a patient's lips. That's not going to do any damage. An alcohol wipe isn't going to cause the room to go up in flames. Or a little bit of petroleum. Okay, you should be okay there. When do we intubate folks? When their actual or potential for airway and ventilation problems is severe. Airway obstruction, actual or potential for. This could be swelling. Okay. In the burn world, we intubate folks with smoke inhalation early because once that swelling kicks in, they're impossible to intubate. Easier to extubate than to intubate. Any ABGs that indicate a severe hypoxemia and hypercarbia, so they're not getting rid of that waste gas. Any kind of significant compromise, cardiac arrest, septic shock, cardiogenic shock, hemorrhagic shock, okay? Any significant change in level of consciousness in which this person's not going to be able to open and keep their airway or their gag reflex or their cough reflex. And this extends to changes in level of consciousness, neck injury, head injury, prolonged seizures, okay? Like a status epilepticus episode. Okay? I think we showed you intubation. Okay? So this is what we do to intubate people. Whenever possible, if we've got time, we tell them what's going to happen. We tell them we'll be gentle. And we tell them that we'll give you something to relax you so you won't even know what we're doing. All right. You could do that pretty quickly. Ideally, these patients should be sedated. No, I'm not talking about the serious car accident victim in the streets with the paramedics. They just intubate those patients. I'm talking about a patient who's deteriorating in the med-surg unit. We need to intubate you. We get some sedative in them first, and then a little paralytic. And then at the same time, we're oxygenating them. We've got their head back. We're ambu to mask, breathing for them. Okay, you need to get that tube in within 30 seconds, or you need to get out of there and re-oxygenate that patient and make another try a little bit later on. Once the tube is in and you've checked it, it's connected to either the ambu bag for manual ventilation or a vent. We verify tube placement. The first thing you're going to see is they're going to check breath sounds on both sides. If I hear more on the right side than the left, then I usually know my tube went in too far. I got to pull back an inch or two, and then I recheck. But breath sounds should be heard equally. The chest x-ray looks for that radiopaque line on the tube, and then respiratory has something called the end-tidal CO2 monitor. You stabilize that tube. You might have to put something next to the tube, because the reflex of the patient is this, if there's something in their mouth, they're going to chew on it. And they can actually chew and kink that endotracheal tube. So we might put a bite block next to the tube, and the bite block is larger than the tube so that when they clamp down, their teeth get clamped to the bite block and leave the tube free. Okay? You also want to know how much tube is hanging out. They usually say the lip line. I prefer the teeth line because the lips can swell. If there's any kind of trauma or surgery, the lips will swell. And if you fill them full of IV fluids, the lips will swell too. So you mark the tube at the line where it touches the teeth. And then you make note of that in your record, and you come back, and if there's more tube hanging out, there's like now an inch between the teeth and the marking, then you know that tube is edging out. Okay? Closely monitor. The day used to be we used to tie them all down, because we thought the first thing to do is go for the tube. And it's true, most people when they wake up go for the tube. But if you've got them sedated and paralyzed, they're not going to go for the tube, so you don't use the restraints. Tube position should be right above here, before the trachea bifurcates. But remember, it's easier to just pass it down the right side, and then you've got to pull it back so that the end of the endotracheal tube is above what's called the carina. The carina is where the bifurcation is. That you don't have to disconnect the endotracheal tube from the ventilator to suction. This system is connected to the ventilatory tubing. The suction catheter is actually inside this sheath, so it stays sterile. You just push it down, and then when you pull back, you press your thumb down to induce suctioning. And this is connected to wall suction up here, so the sputum will pass through and come out. Called the inline suction device, and I'm sure some of you have seen this. Okay. We use mechanical ventilation when the patient's breaths are not adequate. This could be a health event, it could be surgery. Any patient having major surgery will be intubated and ventilated. It just happens during surgery. It's what you do. Okay? Ventilation itself is a treatment of the symptom, not a treatment of the cause, similar to oxygen. Goal is optimum gas exchange for perfusion, and we may need to sedate and paralyze them while they're on this, so that we are actually in full control of their pulmonary function. I'm just going to show you this, and then I think we'll end it and pick up and finish this. We just have a couple slides. This is a unique picture because it actually shows you two vents being used. I didn't plan on this when I pulled it, but then when I looked at it, I saw. This is a vent, mechanical ventilator. This is the endotracheal tube. But you see there's a second ventilator here. There are cases in which, maybe because of surgery or because of trauma, you have to go gentle more on one lung than the other. And so they actually have an endotracheal tube, which kind of has two directions to it, two lumens. And you can actually ventilate one lung with a large amount and ventilate one lung with a less amount and let that heal. And then finally, we'll catch up with the other stuff, but I thought I'll just show you this picture. There we go. That's a patient in the polio epidemic, 1950, in an iron lung, looking at his newborn. Okay? We'll finish up on this. The easy ABG analysis is already posted to the Blackboard. Okay? And I will be posting other tools for you on Blackboard. Please return the attendance sheet.
Hi, Molly. Did you have a really great weekend? How's everything going? How's John Homer? How is he? Is he still here?
Yeah, he's here. He's in the library.
Is that a gift from John Homer?
Yes, this is my new Notre Dame sweater. Wow. It was at Grace's house, so I put it on today. Yeah, he's good. He's doing random stuff right now. And I'm gonna go to the library and join him.
Hey, that's what we're doing.
Oh,
We're gonna go
cool.
eat though.
Birthday girl.
Have a good day.
Hey, good luck.
Yeah.
Hold on, let me sign him real quick.
May hear may not. Molly, text me where you are.
On Friday, that last Friday.
Oh, thank you. Hey, Christine, are you moving your car? Are you moving your car? I was in the front.
Hey, do you guys think when a person intubates another person, hey Charles, they can feel it when they're in? Without, like, with breath sound and all that
I don't know.
And they'd always go, they just did like,
Yeah. Okay. Hopefully I get parking. I don't even have, it's in the other car.